Hello everyone, this is the osteopathic intensivist. I'm going to be reacting to this show that I discovered called Only Human. This is stories of medical school students, generally fourth year medical students in Canada, McGill University. So this is entitled My First Night in the ICU. I'm just going to comment on what I see, a little bit of background about myself. I am a dually board certified in both internal medicine and critical care medicine. I am a member of faculty, and I teach residents and medical students all the time. So let's see what they say. Let's look at this show.
What does it take to become a doctor?
Now you have to take into account that this is Canada.
These are the real-life stories of McMaster Universities on this episode of Med Students. Mona Lee spends a long night alone in the intensive care unit.
Okay, I'm just gonna stop it right there for a minute. Never will a medical student spend any time alone in any part of the hospital for any reason whatsoever. It is a massive liability. They will work with residents. When I was in medical school, I did overnights, but I was with a resident. So never will they be by themselves. To begin with, they're not even licensed. Number two, they're not even a doctor. They're still a student. So that's a little bit of a misinformation there.
Carol, hi there.
Okay, so let's talk about what I see here. All right, so clearly this is an elderly woman. She is intubated. You can see the endotracheal tube here. Does not have an endotracheal tube holder, but rather it's taped on. She is awake, and that's a good sign because we really want to evaluate the patient's neurological status during these things. We want to have them answer questions. We want to make sure that they are oriented. By orienting patients who are on the mechanical ventilator, you reduce the risk of delirium, which is an acute brain attack. So you really want to keep them to as low sedation as possible. And, we use the Richmond Agitation or Sedation Scale, which is the RASS. And to give you an idea, I'm a RASS of 0. So I'm awake, I'm answering questions. A RASS of -1, you kind of fall asleep very quickly. -2, you kind of wake up to voice. -3, you have to wake up to physical, aggressive physical rubbing, like a sternal rub. A RASS of -4 is, you really have to, shake them like crazy, and they might wake up, and a -5 is a coma. A +1 is, they're a little agitated, and then from there you get to +3, +4, which is you're hanging off the ceiling. So, you want to keep them to as little sedation as possible. In addition, studies have clearly shown that, you can have these patients participate in early mobility, get them out of bed, even if they're on the ventilator. Heck, have them walk around. The problem in the United States is that in a lot of places, a lot of small community hospitals where I work, there is very little manpower to help with this. So that's an issue. Another thing, we have, looks like she's on TPN. This could be TPN. So TPN is total parenteral nutrition. For whatever reasons, they might not be able to use her gut. She could be post-operative. You're going to learn in a minute this is actually a surgical resident. She could be discontinued, meaning that they did some kind of surgery and part of the intestine is here, part of the intestine is here, and there's nothing in between. So clearly, you obviously can't use it. She might have other bowel issues and obstruction. She might have what's called an ileus, where there's no peristalsis, and these patients are very catabolic and anabolic, so you've got to give them nutrition. So this looks like it might be TPN. Anything else that I see? She is wearing a isolation gown, so this patient could be a contact isolation, usually because of like an organism issue, an infection issue, such as methicillin-resistant Staph aureus, which is called MRSA. It could be an ESBL positive E. coli, which is extended spectrum beta lactamase. So they're resistant to things like meropenem and other carbapenems, which you don't want to take from one person to another. KPC, Klebsiella, which is another resistant organism. So, the head of the bed should be at around 30 degrees because that reduces the risk of ventilator-associated pneumonia. So let's continue.
I'm Dr. Misra. I'm one of the residents who's working here to look after you as well. I just wanted to fiddle around with this just to see what's happening with your heart, how it's pumping. Okay? It's just one of the lines.
Dr. Mona Lee Misra is a third-year resident training to become a general surgeon. But today, she's working in the...
So what I'm seeing here is this looks like it's white, so it probably is propofol. Propofol is the sedative. Crosses the blood-brain barrier very quickly because it's white, since it's in a lipid emulsion, so it very quickly goes into the blood, into the brain, knocks you out depending on the dose, and then we turn it off, and about 15-20 minutes later you're awake. You just have to watch the triglyceride levels because this is a lipid emulsion, and in some people you cannot give them propofol if they're allergic to egg products because it has egg lecithin within it.
Intensive care unit. Mona Lee is new to ICU.
I don't think she's new to ICU, but by the time you're a third-year resident, you've been in the ICU, especially internal medicine. Surgery, I can't imagine why she wouldn't be in the surgical intensive care unit by now.
Will leave for the night, and
very common for there not to be in-house intensivists. We're very expensive. And so the attending could either be on call from home or you have tele-intensivists. In one of the hospitals I'm in, I'm on call from home. So anything that happens, I'm woken up in the middle of the night. In the other two facilities, not anymore.
Mona Lee will be responsible for the hospital's sickest patients.
Something goes wrong, they only have me. That's the only part that's the most stressful. I know.
I remember when I was a resident, I wanted to go into intensive care medicine, so I was kind of preparing myself, and it is harrowing, because you don't have a lot of support staff in the middle of the night. It's just you. You can have interns, but they're not helpful. The nurses, if they're good, will kind of help you out. Hopefully, your attending is a phone call away. Generally, when you have privileges and there's a potential that you might have to come in for call, you really should be no more than an hour away from the hospital. And so, you can't be 2 hours and expect to be on call. You'd have to move or rent a hotel while you're on shift. But it's very harrowing, being still a trainee and then having the whole place to be on your shoulders,
Nobody's in-house, so for someone else to come in, it would take them about 20 minutes, so I have to keep them alive for over 20 minutes.
Those are pressure socks. We want to reduce the risk of a blood clot in the lower legs, or what we call a DVT.
Overnight, I just sort of continue to be stressed. There's nothing you can really do. You try and relax. My sister lives close by, so I go and visit her whenever I can. The rest of my family's far away in Saskatoon.
Mona Lee is paged to see a patient who needs heart surgery.
So that's what happens. Patient will either come in through the emergency department, or there'll be something happening on the general medical floor, and the floor team is going to call you, or the emergency team is going to call you and say, hey, I need you to see this patient. We would like them in the intensive care unit. And of course, the intensive care unit has a limited number of beds, and it's the most expensive bed in the hospital per day. And so we have to decide, we have to make a decision. Do they need the intensive care unit? Do they not need the intensive care unit? What are the chances of, so when I'm looking at a patient or when the resident calls me with a patient, I have to think to myself, what are the chances that the patient is going to deteriorate within the next 24 hours or until I get there? If I think that it's high or they need very close monitoring, I'll say just bring them in. I'll take a look at them in the morning and I'll decide if I want to keep them in the ICU or I can downgrade them.
This patient that's coming in sounds pretty scary. She's just very unstable, unfortunately. I mean, when they come post, her heart's all fixed up pretty much, and you just have to deal with them. But when they haven't had any surgery for her heart is obviously crap. So these are...
Okay, heart is really crap. So generally when I'm seeing, the patient could either be in heart failure, she could be having an active heart attack.
These are the stressful ones because they can crash at any time. They're obviously doing so badly that it's a little more urgent. So I guess we'll see what happens.
Mona Lee reviews the heart patient's chart.
How bad?
All right, so when I go and I see a patient, I do a quick chart check. What's going on? Why are they here? I want to look at the labs real quick. Have there been any kind of radiological studies that have come in? What am I going into? Because I will be given a quick one-liner as to why the patient was brought to the hospital or why they're in the hospital or why they're in the hospital and what happened. But I generally want to see, especially if they've been in the hospital, what's been going on. So I do a chart check, I look at the labs, I look at the data, and then I go talk with the patient. It also helps me confirm what I'm reading and kind of get an idea as to what's going on.
Is there MI?
So she says, your MI.
So an MI is a myocardial infarction, in medical speak also known as a heart attack.
EKGs are showing sort of gross ischemia.
So the EKG is the electrical reading that we get from the heart, and there are specific patterns that we're looking at, and what they're seeing is that she's actively having a heart attack. So there's areas of the heart that are significantly being deprived of oxygen, and if they don't get fixed, the heart dies, and if the heart dies, there goes the patient.
Great. Oh my God.
So let's see if we can take a quick look. Let me see. So, by convention, this is lead 1, lead 2, lead 3, AVR, AVL, AVF, and then here CV1, V2, V3, and then over here it's CV4, V5, V6. So it would be, V1, V2, V3, V4, V5, V6. So you're looking at the front and lower and side of the heart. All right, AVR is the right side, AVL is the left side, AVF is the feet, and then lead 1, lead 2, and lead 3. So that comes something called Einthoven's triangle, but it gives us a different view of the heart. Mind you, it's mainly the left side of the heart. So if you think it's going on the right side of the heart, then you're gonna have to switch the leads to a right-sided EKG.
When they said diffuse ischemia, they weren't kidding.
Mm-hmm.
This probably came in with the, this is probably the ER, let me back that up for a sec.
Mm-hmm.
So this is probably the ER doctor.
Great. Oh my God.
When they said diffuse ischemia, they weren't kidding.
Mm-hmm.
Wow.
Holy cow. I'm Dr. Nisra. I'm one of the residents working here as well. I just need to put in a line into your wrist here, just so we can keep a good eye on your blood pressure constantly.
So what they're talking about there is called an arterial line. And what they're going to do, they're going to find the radial artery, and they're going to put a small catheter directly into that artery. Now what that's going to do is that is going to measure blood pressure on a beat-to-beat basis. Very important, because if the heart is that bad and she goes into cardiogenic shock, we need to know right away, and the blood pressure cuff will only go off every so often. This is just constant blood pressure monitoring. In addition, it gives us a chance to check an arterial gas to make sure she's oxygenating.
Of just taking it with the cuff all the time, and also they don't need to keep poking you every time they need blood work on you. Okay? Yeah. Oh, great. Okay, yeah. I thought you would.
So she's anesthetizing her first, obviously, because the artery has a lot of nerves. It's very painful. There's a muscle there.
Sometimes it works, sometimes it doesn't.
Oh, are you in there? A new patient arrives who has just had brain surgery.
Brain surgery. So that would be, in a neurocritical care, you want to make sure that, you follow up with the neurosurgeons. You want to know what parameters do they want. Is there a intraventricular drain? So it's a drain that's within the area of the brain that you can remove fluid from. You want to see if they have a bolt, meaning that they have basically it is just a small opening within the skull, and they have a wire in there measuring the pressure within the brain. The skull ain't going to get bigger, and the pressure in the brain can't get in that area can't get too high, or your brain is going to do what we call herniate.
Mona Lee is concerned her blood pressure may be too low.
So if your blood pressure is too low, a couple things are going to happen. First, you're going to not be able to perfuse the brain. Second, the brain is going to try to auto-regulate, so it's going to try to squeeze those arteries, and in order to maintain its own blood pressure, and as a result, the blood flow to the brain is going to get affected, which means the oxygen to the brain is going to get affected, which means the brain cells are going to start to die.
It's exciting, but stressful, so I think my blood pressure is probably higher than hers.
I like that she's calm. You have to remain calm.
Great. Thank you.
But before she treats the patient, Mona Lee consults her neurosurgeon.
Hello? Hi, Dr. DeVilliers. I'm one of the ICU South residents. I just wanted to, the lady that we just brought in right now, what range did you want her blood pressure at?
See, have to know what do they want their blood pressure at. Can't have it too low, can't have it too high. You need to talk with your surgeons. Communication.
It's sitting around 110, 120. Did you want it higher than that? So this is like my first day on call here, so that's why I don't know where exactly the surgeons want the pressures to be, and so I need to make sure with them. I don't want to just guess and do whatever I want to do, because you may get mad.
He's going to get pissed is what he's going to
Do you
get.
want me to go check? What's her mean pressure? What's her mean pressure?
It's 85.
It's 85. Okay, thank you.
So sometimes we don't go by the blood pressure like the 110/80. We go what's called a mean pressure, which is a calculation based on those two numbers.
Yep, bye-bye.
Mona Lee's patient is medicated to try to improve her blood pressure.
So they're putting her on what's called vasopressors. So those are catecholamines, such as epinephrine or norepinephrine, or if outside the United States, it can be called adrenaline or noradrenaline. There's another one that's called phenylephrine. There's another one that's called vasopressin, and there's another one that's called dopamine. They all work on fairly different receptors to get different responses. All in all, we want to keep the blood pressure up.
We never use these drugs. I've never used these drugs usually until I've been in the ICU, so
Right.
I just want to make
They're
sure
titratable. They're very dangerous if you don't know what you're doing.
I'll give her 250 of 5% albumin as well.
So another way to augment the blood pressure is, P1 V1 equals P2 V2, folks. Physics is definitely going to be involved here. So you want to give a volume expander. The problem with giving crystalloids such as normal saline or Ringer's lactate is that, within 20 minutes that gets extruded into the third space. So they're going to start getting puffy. Albumin is what's called a colloid, so it has a tendency to stay in the vascular space for a much longer period of time. However, they did a study, it was called the SAFE study, the SAFE trial, in which they tested albumin versus saline, and what they found, there was absolutely no difference. It was just more expensive.
Mona Lee's brain surgery patient continues to be unstable and needs to go back on a breathing machine.
So she was probably extubated when she came out of the operating room, and either her blood pressure is still dropping, she is getting agitated, which is not good for a brain. which you're monitoring the pressure of, because it's going to cause an increase in the intracranial pressure to the brain. If you increase the intracranial pressure, you're going to drop the cerebral perfusion pressure, which is mean arterial cerebral perfusion pressure is mean arterial pressure minus intracranial pressure. And so if you drop cerebral perfusion pressure, blood flow is limited to the brain, oxygen is limited to the brain cells start to die, swelling gets worse, and it's what we call a death spiral. So with the blood pressure getting lower, what may be happening is that she's developing what we call an acidosis. So there is acid building up, and her body's going to want to try to relieve that by breathing faster. And if you relieve that and you breathe out too much carbon dioxide, again, those blood vessels are going to clamp shut, and as a result, not get blood flow, not get oxygen.
He suggested we re-intubate her, gently hyperventilate her overnight, and start her on some mannitol.
So, there's an increase in pressure in the brain. Mannitol is what we call an osmotic diuretic. Although, if she is on pressors, I would have rather suggested hypertonic saline. And if she's in an ICP crisis, maybe 23% saline as a push rather than mannitol, because you're going to drop that pressure because it's a diuretic.
I'm going to give you a little spray.
I'm going to do an awake intubation.
ICU physician Dr. Cindy Hemlick supervises as Mona Lee attempts to re-intubate.
Right, so that's what I do. I'm the ICU intensivist. I'll have my resident, if they want to intubate, I'm generally right here in the event they can't get it and I need to rush over there.
Doesn't taste very good, does it? I know, I'm sorry.
All right, I completely disagree with what's going on. If we're concerned about intracranial pressure, I would never do an awake intubation, because that is just going to cause her to put more pressure on the brain.
I can't even see her cords.
And I would use video laryngoscopy.
So take it right deep to the back and just lift.
So that's a straight blade. It's called a Miller blade. It's straight. It's got a little curve at the end. It looks like it's a Miller 4. It's a little longer. You go right to the epiglottis, put it into the vallecula, and lift up. There you go.
The patient's narrow airway proves to be too difficult for Mona Lee.
Hey, what size tube would you get?
Now I would use a 7.5. 8's too big.
Don't feel bad about not getting that, but she's really tiny. That was a hard one there. Okay, so
You have to tell the residents, listen, you're not always going to get it. I don't always get it.
you happy to plan for them? Okay, and I'm only 10 minutes away, so if you need me, don't hesitate.
Thank you so much. Okay.
This is probably a pulmonary critical care doctor. Probably going to the office.
It's now 10 p.m.
Nope, she's going home.
Time for Dr. Hemlick to leave for the night. For the next 9 hours,
10.
26-year-old Mona Lee is the senior physician in the ICU.
So that was first part of my evaluation of the series. What we'll do is we'll continue it from where we left off in the next episode, and I look forward to going over it with you. Thanks.